here we have just an overview of some of the structures. Okay, here we have an overview of some of the structures related to the abdomen. First of all, we have the abdominal wall, as you know, composed of the skin, and then you have the superficial fascia. This is the Camper's layer, which is the fatty layer, and the membranous layer cannot be distinguished, which is Scarpa's layer. Okay. Beneath that, you have, as we know, you have the muscles of the anterior abdominal wall. Here we can distinguish the external oblique. As you can see, its fibers are arching downward and medially. See the fibers? You can say that these are the fibers of the external oblique. Its nerve supply is from the lower six thoracic nerves, and basically that, yes, lower six thoracic nerves. Then you go a layer deeper, you have the fibers of the internal oblique muscle. As you know, it's directly at a right angle. This is external oblique, this is internal oblique, going upward and medially. And it's supplied by nearly the same nerves. Then the transversus, well, seriously, we cannot really distinguish a transversus muscle here. No, not even this. We cannot even say that this is, no, this is rectus actually. I cannot, maybe transversus lies here, but we cannot say for sure. No. Okay, so external oblique, internal oblique, then the muscle that lies in the midline, on either side of the midline actually, is the rectus abdominis muscle. This is the rectus, the right rectus muscle. Okay? And we can say this is a tendinous intersection. Okay? Alright. Then we go deeper. Let's go to the other side. So now we've reflected the skin and the fascia, and we've reflected the muscles. We said that the aponeuroses of the external, internal oblique, and the transversus join to form the rectus sheath that encloses the rectus muscle. And we said that this is the rectus muscle. So these are the two layers of the rectus sheath, anterior and posterior. Okay? And behind the rectus sheath, you have the parietal peritoneum. This thin, loose layer, it's visible on this side. This is it. This is the parietal peritoneum. Okay? This one. And it has the same nerve supply as the wall, as the abdominal wall. Alright, so this, of course, is the umbilicus. As you can see, it is tightly tethered to the underlying tissue. All the other parts of the skin of the abdominal wall are loosely attached to the underlying structures, but the umbilicus is tightly tethered. So, now we go deeper into the peritoneal cavity, not the peritoneal cavity, the abdominal cavity. And as we said, the first structure that we see when we open the abdomen, let's reflect it further and into its original position, is of course the greater omentum. This is the greater omentum. All of this, okay? This yellow structure. Now we're going to reflect the greater omentum upward. We see that it's attached to what? The transverse colon. Okay, but more about that later. The greater omentum, of course, comes from the stomach, but we cannot see the stomach because it hasn't been dissected yet. No, we cannot. Leave that. So, now we've reflected the greater omentum. We have, since we can't see the stomach, then we follow the small intestine. You can see here. This is, from here it's the small intestine, okay? You can see all these coils. You can reflect them all here. All of this is the small intestine, okay? All the way down until it reaches what? It reaches the large intestine, okay? Yes, we have more detail about it. Let's go back to the small intestine. So, we said the beginning of the small intestine. Sorry. Okay, so messed up. Alright. What can we see is that it is attached, what we can see is that it's attached to the posterior abdominal wall by way of this mesentery, okay? The mesentery, you can think of the intestine like this. The mesentery comes like this, folds it, and then goes back. Okay? So it's the same case here. The mesentery comes in this direction, enfolds it, and goes back to the wall. Okay? Within the mesentery, you have fat. This is the layers of the fat. Of course, the first part of the small intestine is the duodenum, but we need a more detailed dissection of the thorax. Probably, okay, there's also no ligament of Treves, so we can, I don't know, maybe this is the duodenum, and this first part, which comes from the lesser sac behind. Okay, the lesser sac is supposed to be behind. This is probably the duodenum, coming forward and becoming the jejunum. Mainly the jejunum lies in this region. As we go more down toward the right iliac region, we can see that this is the jejunum. All right. An important difference between the duodenum and the jejunum that we can see here is that in the case of the jejunum and ileum, the difference between jejunum and ileum. In the case of the jejunum, the fat is more located at the base of the mesentery, not at its tip. Whereas in the ileum, you can see that the fat is prominent even near the wall of the intestine. Okay? See, they are protruding. But if we go back to the jejunum, there's no such thing. And it just reaches the base of the intestinal wall. It doesn't protrude above it, like in the case of the ileum. Okay, another difference, the wall of the jejunum feels like it is double layered, okay? And if you feel it, it is thicker, it is larger, because its plicae circularis are more numerous in number, they are larger and they are more closely set together. Whereas the ileum is thinner, and its plicae circularis are the opposite of those of the jejunum, okay? There are other differences, but this is what is visible here. The blood vessels, of course, in the case of the jejunum, you have more simple arcades and less vasa recta, which are longer. But as I said, these are not visible, so we don't mention them. The important thing is to differentiate in the exam or in surgery, to differentiate between the jejunum, which has a thicker wall, and the fat is distributed more toward the base of it. If we can see the base. Yes, probably you can see. You can see more fat near the base, rather than being distributed evenly. Whereas the ileum is thinner, and the fat is distributed evenly throughout, even near the wall of the intestine. So I believe there was also the mesentery. Okay, see. Let's see. Yeah, and you can see here that the intestine is attached to the wall by way of this mesentery. This is the mesentery, okay? This layer. It's going back to the to the posterior abdominal wall. On the right side, yes, we can also, and you see it, the mesentery extending from the intestine to the posterior abdominal wall. Okay? All right. Yes, and also on this side. And we said on the other side, we can see that, the layers of peritoneum lining the intestine going back to the posterior abdominal wall. All right, you can see the layers here. And it's, of course, the same on the right side. And they say that, theoretically, we don't see it here, that the root of the mesentery of the ileum is attached to the right side of the aorta, to the right of the aorta, whereas that of the other, of the jejunum is to the left side. It's just not visible here, okay? And this is basically the mesentery, going back to the posterior abdominal wall, okay? All right. Then if we go down to the terminal ileum, this is the terminal ileum, okay? All right. So, here, as we all know, the ileum joins the large intestine. This is the ileum joining where? The large intestine. At this point, this is the ileocecal junction. This is the ileocecal junction. Where is it attached to the large intestine? At the junction of the cecum with the ascending colon. At the junction of the cecum with the ascending colon. So, we have the cecum. Here, this is the cecum. You can see that it's not distended. This is the cecum. Take a good shot of it. This is the cecum. And you can see joining with the ileum. Attached to the posteromedial wall of the cecum is the appendix. This is the vermiform appendix. Okay? So this was the this was the terminal ileum. This was the terminal ileum going to the large intestine. Here we have the cecum, this, and attached to its posteromedial wall is the appendix. So we have the appendix here. Okay? Okay. Then after the appendix, we need a helping hand here. Wait a second. This is the large intestine going down. You can say basically this is the large intestine because we cannot reflect it all. This was the cecum, this was the junction, so above it is the ascending colon. Here. Okay? And is it visible? Then you go up, we can only say this is the region of the hepatic flexure. If this is not working. Alright. This is the region of the hepatic flexure, or the right colic flexure, where the ascending colon becomes the transverse colon. Okay? If you can take a wider view so that the people know where we are, the orientation. This is the abdominal wall reflected. Here we have the ileum terminating at the cecum. Going up you have the ascending colon. Then you have the right colic flexure or the hepatic flexure. Then you have the transverse colon. Okay? So, now we said the greater omentum in the beginning, we said it's attached to the transverse colon. This is the transverse colon. Okay? And it is structure here. As we said, it extends from the hepatic flexure transversely across the abdominal wall and then goes to the left. Here, at this region, this is the splenic flexure. Okay? Here. Where the transverse colon becomes the descending colon. So this is the region of the splenic flexure, or the left colic flexure. If you go further down, you get the descending colon. That's it. So you can see posterior abdominal wall. This is the descending colon. Okay. If you go further down, you can see an irregular alignment. How should we take a picture of this? Yes. You can see that its orientation changes. This is the sigmoid colon. Okay? Here. We have the sigmoid colon. Yes, this is a very good shot. This is the descending colon becoming the sigmoid colon, and the sigmoid colon turns down to become the rectum. Alright? It goes down to become the rectum. That's not our subject there. So, a distinguishing feature of the large intestine, the external features, is that it's larger, and it's located more in the periphery. It's located more in the periphery. So you have the coils of jejunal ileum in the middle, and it's surrounded in the margin by the large intestine. Another point is the presence of these fat tags. These fat tags, okay? Globules of fat surrounded by peritoneum. It's called omental appendices, or appendices epiploiky. And it's attached to the tenicoli. Yes, by the way, the tenicoli. The doctor said this is a tenicoli here. A tenicoli is a longitudinal smooth muscle band that is found in three bands found in the wall of the large intestine. And by its presence, you can distinguish the large intestine from the small intestine. And to the tenicoli, you have the attachment of the appendices epiploiky. Right. And if we go down We forgot one thing about the intestine and the abdominal wall, the inguinal canal. And that's basically what is there in the abdominal cavity. What is left is about the spermatic cord. Okay, if you can take a closer shot here. So this is the inguinal region. Okay, it's just the spermatic cord opens. Here we have the superficial inguinal ring. You can see this? You can see this opening here. That's the triangular deficit in the aponeurosis of the external oblique. Okay, so we said we are in the inguinal region for your orientation. This is the abdominal wall, this is the inguinal region. We go where? To the aponeurosis of the external oblique. We said this is the external oblique. These are the fibers of external oblique coming downward. Okay? As they come downward, we said there, and it becomes more of aponeurosis. So you have a deficit in the aponeurosis of the external oblique. This is the superficial inguinal ring. Alright? In the male, there is the passage of this spermatic cord. This has been opened, by the way. The spermatic cord was, more visible as the original structure before dissection. But now you can see this remnant of it, the contents pulled out of the spermatic cord. And in the females, the round ligament of the uterus. Now, if we go into the canal, I believe the canal is visible if we go a little deeper. Yes, this is the deep inguinal ring, position of the deep inguinal ring. Okay, so this was the superficial inguinal ring. If you go deeper, this has been dissected, by the way. This is the deep inguinal ring, the position of deep inguinal ring in the fascia transversalis. So, in the spermatic cord, as you can see, the fascia has been opened. A second. All right, and here we cannot separate the veins of the pampiniform plexus and the vas deferens. Probably this is the vas, okay, ductus deferens or vas deferens, and the others are the veins of the pampiniform plexus here. Okay, I'm not sure. This, let's see, what's this? It's fascia. Okay, all right. So this is probably the vas deferens, and you can see it originates from where? From the epididymis. This is the epididymis. It's visible, separate. Let's see. Yes, this is the epididymis. From the tail of the epididymis, it goes up. And this is the testis. It's covered by tunica albuginea. All right? That's basically it.